severely complicated fractures, about 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing. Unlike conservative management, it provides stable fixation and early mobilization and reduce the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage, and fewer potential complications, making it an attractive option for managing distress fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, or were simple distress fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, no traffic accident was the main mode of the trauma, whereas fall from height and fall on out-stress side was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeters displacement. And the next type of condition are the radiological indications for the surgical treatment, either in the form of tense or internal fixation with the plate and screw. So these are already explained. The simple fracture were taken into consideration. Distressed simple fractures are spiral or oblique or transverse or short oblique between D1 and D2. The patient lies supine on a affected lip, elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the abduction of the fracture by closed wing. The incision is small incision and a transverse or longitudinal incision about 1 to 1.5 centimeters, just lateral to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate post of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, at 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15B1 fracture treated by titanium elastic nailing, yet another case of 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture, this is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see the 6-month follow-up, the beautiful radiological union. This is the functional result. You can see So the time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is tense nail is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science.
Save time creating content and generate a high-quality clone of your voice with 11 Labs.
17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a garage fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture combined with the complex bone fracture and dislocation, which we call the garage fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture, a 17-year-old gentleman, and the forearm pelagic fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this pelagic fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for pelagic fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of pelagic fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking, it was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive. And whereas in this left radius, the pelagic fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for pelagic fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors are been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union, but This is the functional result. You can see that supination, pronation, and wrist movement, erection and extension all are present. And the tense swelling provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained and DREJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DRG maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is it's minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and TENS yields higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences.
Owner dependency is a curse for your business. If everything is dependent on you, marketing, sales, operations, human resources, accounts, then you built a trap for yourself. You're not building a business. If you'd like to break through,
provide stable fixation and earlier mobilization and reduce the risk of non-union and malunion. TENS is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years and no comorbidities are found in our study group. All patients treated with titanium elastic nail. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicate fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. 15B1 is a spiral and oblique, whereas 15B2 is a transverse and short fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision, there is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is the very crucial step. And then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we We did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up was 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the one stitch surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did, the 15B1 fracture again treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. One bump is due to secondary callus formation, and other at the entry site you can see that there is hardware from this. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS snelling is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here.
मैं महीनों से एक YouTube क्रिएटर के रूप में वीडियो बना रही हूँ, लेकिन ना 1000 सब्सक्राइबर पूरे हो रहे हैं, ना 4000 वॉच आवर्स, और बिना मोनेटाइजेशन चैनल से कमाई कैसे शुरू होगी? फिर मुझे मिला UCO, अल्टीमेट यूट्यूब क्रिएटर टूलकिट। इसने मुझे दिखाए सही वीडियो ट्रेंड्स, मेरे पुराने वीडियो के SEO फिक्स किए और सही कीवर्ड्स बताए, जिससे मेरे वीडियो सही ऑडियंस तक पहुंचने लगे। UCO की मदद से मेरे चैनल की ग्रोथ तेज हो गई और फाइनली मेरा चैनल मोनेटाइज हो गया। व्यूज और सब्सक्राइबर्स की वो टेंशन अब खत्म। मेरा एक सक्सेसफुल यूट्यूब क्रिएटर बनने का सपना अब सच हो रहा है। अगर आप भी अपने चैनल को ग्रो और मोनेटाइज करना चाहते हैं तो आज ही UCO डाउनलोड करें।
फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। अब नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सीआर के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सीआर को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है, अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से सीआर को एडजस्ट किया जाता है कि वो गोल दिखे और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सीआर को एडजस्ट किया गया है और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blunt dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am hammering the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the every view it has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce the help of the F tool. During reading process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. I am doing reaming with a 10 millimeter reamer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in every view, and also in lateral view. This is the oblique view. And after performing in the CR, in both views, we did reaming up to the lower end of the femur, and finally we reamed this fracture with the help of power reamer 11 millimeter. Because the patient is old one, so reaming is easy. It is just to measure the size of the intermedullary canal, the diameter of the intermedullary canal, the what size of the nail should be introduced so that it can fit in the intermedullary canal. The fitting nail can be introduced. So this is the purpose of reaming. Because the patient is old one, osteoporotic, throughout the nailing process, reaming process and nailing process, the fracture is kept in reduced position by my assistant, and the fracture has been reamed up to the upper end of the patella, as you can see in the CR picture. You can see in the CR picture it is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter, sorry, 11 millimeter nail on cheek. And finally, I keep in mind that before locking, you have to remove the guide wire. And I am doing proximal locking. The proximal hole in the proximal fragment near cortex is perforated with the help of 2.5 millimeter K wire, and the distant cortex is drilled with 3.2 millimeter drill bit, and finally we select a proper size 5 millimeter screw for proximal locking, and I am still making a hole in the distal fragment, distal cortex, and now I am tightening the screw, the second screw in the proximal fragment. As you can see in the CR picture, the proper size screw has been tightened in proper position, and it is confirmed that it is inside the hole in both anti and lateral view. And now I will do the distal locking by freehand technique. I will make the hole circular after adjusting the CR in lateral position, and I am tightening the screw after drilling with 3.2 millimeter drill bit. As you can see in this picture, and both the screws have been tightened and confirmed in LT and lateral view. The size of the screw is confirmed in the LT view, and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw is slightly larger than it should be, but it was accepted because the effect of anesthesia was wearing off. So it was accepted. And you can see that both in LT and lateral view, both proximal as well as the distal screw are in place and in proper position. And now I am going to close the wound after forceful wash of the wound so that now I am closing the wound after forceful wash of the wound. Now the wound has been closed. The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage.
The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number 2 is there is always chance of radial nerve injury, as it is a complication for the interlocking nailing of humerus. And it is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spinal root. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, remove, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies whether which position of the patient should be used for the interlocking nailing of humerus. There are three positions. Number 1, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeons. But the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slipping of the drill bit or KY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry hole, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons, it depends on the surgeon's choice. So I do use supine position for all my interlocking nailing. Number 3 controversy is because it is non-weight bearing bone. So one screw distal and one screw proximal is sufficient. But I use 2 screw distal and 2 screw proximal because the 2 is always better than 1, always stronger than 1. If it is just like the 2 kidney present in human body, if one fails, others start working. So, and 2 engines in the aeroplane, one engine fails, the other start working automatically. So, if one screw is not working, then the other screw will do its work. So, the fixation is better by 2 screw proximal and 2 screw distal. So, friends, these are the advantages of interlocking nailing over the plating of the humerus, and these are the myths, and these are the controversies whether 2 screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel for more update on orthopedic surgery and insight.
Oof.
सॉफ्टवेयर में, इन्वेंट्री दूसरे में और हिसाब किताब तीसरे में।
ये है मिस्टर प्रशांत कुमार जो असम से आए हैं। उनके दाहिने कूल्हे का एक्सरे पिक्चर जैसा कि आप देख सकते हैं काफ़ी डिफॉर्म्ड हो गया है और एक दूसरे में चिपक गया है। कूल्हे का हड्डी कूल्हे का गोला कप में चिपक गया है और काफ़ी हड्डी बन गया है उनके। इसके कारण काफ़ी रेस्ट्रिक्शन मूवमेंट में उनको हो रहा था। वे ठीक से बैठ भी नहीं पाते थे कुर्सी पर। ये है एक्सरे पिक्चर जिन्हें टोटल कूल्हा उनका बदल दिया गया है ऑर्थो सर्जिकल केयर सेंटर में। और 10 दिन के बाद वो वॉकर पे चल रहे हैं और फिर सीढ़ियों से उतर रहे हैं। इसमें ध्यान ये रखना पड़ता है कि उतरते समय पहले प्रेशर वाले पैर को बदला गया है, उसको पैर रखना, उस पैर को रखना है। उसके बाद अच्छे पैर को रखना है और चढ़ते समय पहले अच्छे पैर को ऊपर रखना है। उसके बाद जिसमें कूल्हा को बदला गया है उसको रखना है। ये आप ऑपरेशन के बाद एक कुर्सी पर बैठ सकते हैं, इवन लो चेयर्स पे भी बैठ सकते हैं और काफ़ी कंफर्टेबल और पेनलेस मूवमेंट ऑफ नी जॉइंट आप देख सकते। ये बिना सहारा के 10वें दिन बिना दर्द के चल पा रहे हैं।
छपरा के डॉक्टर आरसी ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान बनाई है। उनकी तकनीक से 35 लाख रुपए तक का महंगा इलाज मात्र 35,000 में संभव हो सका है। ऑर्थो सर्जरी में योगदान के लिए गुवाहाटी में आयोजित इंडियन ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की बात है।
इनोवेशन अवार्ड इंडियन ऑर्थोपेडिक एसोसिएशन द्वारा शुरू किया गया है, जो कि गुवाहाटी IOACON 25 में दिया गया है। और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है जिसमें मेरा नाम आया है।
The supine position of the patient with a bump in the interscapular space, in which position I do interlocking nailing of humerus. With the traction only, with the assistant, both sides, the traction is given, and external rotation of the proximal fragment is done with the hand only. As you can see in this picture, evident in the fluoroscopy picture, you can see, and I am externally rotating the proximal fragment to see the lateral view of the fracture. So after reduction of the fracture in both epic and lateral view and confirmed on the fluoroscopy picture, we make we introduce a 2.5 millimeter or 3 millimeter K-wire or steamer pin percutaneously at the selected entry point both in AP and lateral view. The entry point is usually in AP view, it is at the point at the junction of the articular and non-articular fracture. And lateral view, it is in the line with the intramedullary canal. So if the fracture is in the upper part, upper fourth of the humerus, the entry point is in a AP view, it is in intra-articular surface of the humeral head, because it should be central in both AP and lateral view. So I am introducing 2.5 millimeter statement pin percutaneously at the selected entry point. You can see this is the AP view. I am selecting the entry point. It is intra-articular portion of the. You can see in this picture, because the fracture is the upper fourth of the humeral shaft, and this is the lateral view. I am seeing it in the lateral view. It is inside in the line of the intramedullary canal, and it is inside the intramedullary canal in both an AP and lateral view, confirmed in the fluoroscopy picture. And I am exchanging this statement pin with a kind wire. A 2 millimeter kind wire is exchanged for this statement pin, 2.5 millimeter statement pin, and after making a stand hole, after making a small ring in the rotator cuff, and this is my right wire is inside the proximal fragment in the proper position inside the intramedullary canal in both the lateral view, and you can see the fraction is reduced. And take your time while introducing the fracture side, while crossing the fracture side and introducing the line wire in the distal fragment. It should be reduced, the fracture should be reduced in both AP and lateral view. And now I am inside the distal fragment. Don't put the guide wire inside the soft tissue, and don't try. Then this is the reading of the intramedullary canal. Serial reading is done. First of all, with the 6 millimeter reamer, and it is being read, and then the 7 millimeter reamer is used up to the lower end of the humerus. It is about up to the 2 to 2.5 centimeter, proximal to the 8 millimeter the reamer is being used in this picture, as you can see in active view, and it is crossing the fracture site. You take the proper time, and the fracture should be reduced while doing reaming, and it should not be in varus and valgus position, and it is inside the distal fragment. As you can see in this picture, the 8 millimeter reamer is inside the distal fragment, is introduced. So after reaming, we introduce a 7 millimeter nail of appropriate size with hand movement only. Don't use electric reamer or hammer. Only the last few centimeters of the nail is introduced by hammering. So it is a well-placed nail up to about 2 to 2.5 centimeters above the alveolar fossa. And now I am deciding where I should put my incision for distal locking. And this is the K-wire position on the skin, put on the skin horizontally, another K-wire vertically overlapping the nail and crossing the hole. So where the both KY cross each other, the bisecting point in the middle of the proximal hole, dynamic hole, will be my point of incision in the skin. So after putting about 1 to 1.5 centimeter length skin incision, we do dissection, soft tissue dissection with the fingers or the artificers, and then a 1.5 millimeter KY, sharp KY is used to make a hole. After making both holes circular, the lower hole circular and relaxing the upper hole, dynamic hole in the blade as much as possible. And this is the 1.5 millimeter KY is being put. You see, this is put in angle because the shape of the anterior surface of the distal humerus is triangular, so it should be put in angle. So introducing in near cortex, we do drilling of the distal cortex through this hole, and after drilling, we have put both the screws. You can see in AP and lateral view where size screw and where placed screw inside the hole in both AP and lateral view. So I am putting the proximal screw down. You can see that the nail has been buried about 5 millimeters from the articular surface inside the intramedullary canal. The first screw has been put with the help of the G and drill sleeve and the sleeve. Both the screws have been put. The west side screw you can see, and I am confirming it in oblique view as a lateral view, even along with the jig. You can see that the jig is in place, and still I am confirming it whether it has gone inside the hole properly or not, and well placed to both the screw inside the both hole, well sided screw in the view, and well placed screw in the lateral view also. So this is the last step. And first of all, I do distal locking because the back hammering of the nail is done when required to reduce the distraction at the fracture site, to eliminate the distraction at the fracture site, and the fracture is compressed. But in this case, there is no distraction at the fracture site, and nail has been buried inside the intramedullary canal about 5 millimeters from the articular surface of the head. So this is the lateral view and AP view of fluoroscopy picture. You can see this is the lateral view, well placed distal screw, well sized distal screw, and this is the AP view, and you can see the final position. There are two skin incisions, one for the entry of the nail and other for the proximal to the screw. So these are the last confirming fluoroscopy picture. You can see well placed screw and well buried nail about 5 millimeters from the articular surface. This is the fracture. You can see there is a communicated fracture. There is no distraction. Okay, thank you.
पोस्टर मेकर ऐप डाउनलोड करो, पाओ रोज वायरल वीडियो अपनी ब्रांडिंग के साथ सिर्फ 9 रुपये।
I'm just lazy. What is actually happening is your brain is protecting you from perceived threats. I lack
the traditional teaching that the